Hi, my name is Brendan O'Leary, and today in this presentation I'll be discussing seizures and the impact status epilepticus has on patients in the pre-hospital environment. Seizures impact approximately 10% of the global population, with 1 to 2% of these people around the world being diagnosed with epilepsy. Given our current knowledge and understanding of seizures and the various types, it is important that we are constantly evolving to ensure we remain up to date with the relevant information. Without appropriate definitions and classification systems, patients may result in improper treatment and diagnosis. Within this presentation, I will be specifically looking at status epilepticus as a seizure type, discussing the pathophysiology behind the condition, the clinical features associated with its presentations, as well as a physical examination performed in this scenario. Pharmacology will be discussed, both in the pre-hospital and hospital environment, and relevant investigations that will likely be required, which will also have an impact on the transportation decision-making process and leadership roles within a scenario involving a patient with status epilepticus. Status epilepticus, or SE, is a common neurological emergency affecting young children and older adults disproportionately. SE has an associated mortality of approximately 0 to 3% in young children and 20 to 30% in older adults, with survivors often being impacted by long-term neurological and cognitive deficits, highlighting the importance associated with optical care and time-critical nature. Whilst the pathophysiology of SE is not completely understood, it is important that we review what is known. To be able to understand the complex pathophysiological process of SE, we must first understand the pathophysiology of seizures. Genro and Aselovich, 2019, stated that a seizure is a situational clinical event that may be instigated by any number of extrinsic or intrinsic precipitating factors, and that results in an excessive hypersynchronous discharge of a cortical neuronucleal population and manifests in the brain in either a localized or widespread manner. This means that abnormal activity takes over the normal functioning of one or more brain pathways that result in seizure-like presentations. Once epilepsy is established, it can spontaneously override some of our typical normal pathways, resulting in reproducible patterns of seizure types. There are two distinct pathophysiological processes that define status epilepticus, and they are those that lead to prolongation of the seizure and those that lead to its pathophysiological consequences. What results in the termination of seizures? Well, there are a number of biological processes that lead to seizure termination, including neurotransmitter depletion, ATP depletion, ionic changes, acidosis, increased GABAergic drive, release of adenosine, and release of peptides. When suppression or failure of these mechanisms occurs, status epilepticus may ensue. During this period of seizure activity, there may be a pro-seizure process occurring as well, resulting in increases in seizure length. These include the breakdown of the blood-brain barrier, inflammation, and increased expression of pro-epileptogenic peptides. It has been found that there is a spatial and temporal synchronization which occurs prior to the postictal phase. This observation has resulted in a belief that there is a critical transition from an ictal to a postictal state. SE can be considered a failure to cross that transition, as there is a repetitive approach to this transition before retreating into an ictal state. As can be seen in the following figures, during mid-seizure there is a higher proportion of pro-seizure processes in the ictal phase, demonstrated in figure C, as opposed to the postictal phase. As the spatial and temporal synchronization occurs, mechanisms of seizure termination occur, where EEG activity begins to demonstrate a balancing before moving into a postictal state, which is demonstrated in figure A. In SE, the normal processes of this synchronization are unable to occur, and there is a constant relapse into the ictal phase. Observable signs of status epilepticus are dependent on whether the patient is suffering from continuous generalized convulsive status epilepticus, is having recurring generalized seizures without a full recovery, or is having non-convulsive status epilepticus. Visible signs may include an initial tonic phase where muscle tone is increased with no visible shaking, an epileptic cry due to pharyngeal spasm, rhythmic clonic movements, nystagmoid movements of the eyes, and a postictal period, where there is a period of confusion or fatigue. Given SE is a life-threatening condition, early recognition is important. The presentation of status epilepticus is quite varied depending on the neurological pathways impacted. Patients may present with simple partial seizures with no impaired consciousness, which is represented in 3.4% of cases, partial seizures evolving to generalized tonic-clonic convulsions in 36% of cases, or generalized seizures, convulsive or non-convulsive in nature. The identifying factor in the clinical presentation of a patient with status epilepticus is that there is no postictal phase. Other identifying clinical features can include a decreased GCS, with 58% of patients presenting with a GCS less than or equal to 8, and 63% of patients being considered in a comatose state at the initial time of evaluation. The table below demonstrates some other features of status epilepticus. Due to the systemic impact SE has on the body, there are a number of other manifestations that the clinician must be aware of. These clinical features may include acid-base disturbances, where a majority of patients presenting with SE will also present with acidosis, which is likely due to be a result of impaired ventilation and release of lactic acid into the bloodstream during convulsions. Hypothermia, which is due to the ongoing muscle activity during convulsions. Body temperatures may have been seen to be elevated and may not necessarily indicate an infective etiology. Circulatory and respiratory changes, where there is an initial release of catecholamines into the circulatory system, which may result in an increase in heart rate and blood pressure, as well as potential cardiac arrhythmias. Late stage in status epilepticus, there is generally an occurrence of hypotension. However, this is also associated with drug regimes, which can also be a potential iatrogenic cause of hypotension. Hypoxia is another common presentation, as well as electrolyte disturbances. Blood glucose tends to fall after prolonged convulsions after an initial rise at onset, with blood glucose potentially declining to below normal levels due to an increase in insulin secretion in late stages of convulsive activity. Rhabdomyolysis is a less common clinical feature to be aware of. However, it results from prolonged periods of convulsion and often in association with hypothermia. Interestingly, a case study presented by Ji Qing et al. 2017 found that aphasia, although rare, can potentially be an identifying factor in a case of status epilepticus, which should lead the clinician to have a heightened awareness of any neurological symptoms with or without a history of epilepsy. Physical examination should always consist of a comprehensive primary and secondary assessment. Identifying airway, breathing, and circulatory compromise should result in immediate efforts for resuscitations, with focus shifting from these areas once adequate control of these aspects has been obtained. Once a primary survey has been completed, rapid anti-seizure intervention needs to be performed, followed by a systematic approach to a secondary survey. Obtaining vital signs to identify any derangement from normal values will help direct treatment pathway, with the clinician ensuring that any systemic abnormalities be addressed. Identifying potential injuries or causes that would result in seizures is also important. With history being obtained, can be provided to the treating team on arrival to hospital. This will aid in the development of a more in-depth treatment plan if current anti-epileptic treatment plans have been ineffective. In New South Wales Ambulance, midazolam is the indicated medication for seizures. Benzodiazepines have been indicated in pre-hospital seizure management for a significant time. These medications are used frequently in seizures and status epilepticus due to their rapid onset of action, high efficacy rates, and minimal toxicity. They act upon GABA-A receptors, promoting a depressive state of the central nervous system. Separate channels for GABA and benzodiazepines are attached to a common chloride channel, which increases the frequency of its opening. This process is related to controlling the excess GABA action occurring in the CNS. Delays in administration of benzodiazepines result in a loss of efficacy during status epilepticus, and early administration of benzodiazepines results in a reduced mortality rate as well as limiting the possibility of new neurological deficits. In the hospital setting, Frontline medications considered for use are benzodiazepines, which are given initially in 89% of patients. In status epilepticus, midazolam is administered at a dose of 0.2 mg per kilogram up to 10 mg IM, or lorazepam, which is given 0.1 mg per kilogram up to a maximum of 4 mg IV. There are a number of other medications that are used in second and third line treatment. Phenytoin follows the administration of benzodiazepines, which was seen administered in 79% of patients at 20 mg per kilogram. Phenytoin has been found to be more effective in patients with lower BMI who have had a previous history of seizures and/or epilepsy, and patients with tonic-clonic seizures. It is an anticonvulsant medication which acts upon sodium channels by blockade of the voltage-dependent membranes, which are responsible for increasing action potential. Essentially, this works by blocking the feedback loop of high-frequency repetitive firing, which prevents the spread of seizures. Valproate sodium, which is often given at 20 to 40 mg per kilogram, is also considered a second-line treatment. As mentioned previously, impaired GABA levels are considered a pro-epileptic process. Valproate sodium acts in different ways, with one mechanism of action including the blockage of voltage-gated ion channels and acting upon GABA levels in the CNS. Valproate has also been considered to reduce the high-frequency firing of neurons through voltage-gated channels. A lack of data is there to suggest a preferred choice, order, and effectiveness of anti-epileptic medications, so it is often up to the clinician's decisions. In patients who remain in a refractory status epilepticus state, despite first and second line treatments, should be intubated and placed on continuous midazolam therapy or propofol infusions. The mechanism of action for midazolam has already been discussed. However, propofol is an anesthetic used during general anesthesia and in refractory status epilepticus. The mechanism of action is poorly understood, however, is believed to have an impact on the GABA-mediated chloride channels, decreasing association between GABA and GABA receptors in the brain. This results in chloride channels being open for longer, making it more difficult for action potentials to fire. It is imperative to begin anti-seizure therapy prior to investigating the cause, but once this treatment has commenced, balance then shifts towards identifying an etiology. In the pre-hospital environment, this is difficult to identify causes. Therefore, relevant investigation focuses on comprehensive primary and secondary assessment, followed by a thorough history taking to identify time of onset, events precipitating the seizure, associated symptoms, relevant medical history, medication history, compliance, and any allergies. It is important to identify the causes and consequences of the seizures, predetermining factors of the occurrence of status epilepticus, as well as the prognosis of the current seizure. Craig, Mitchell, and Thomas, 2020, state that first-line investigations should include basic laboratory studies, which would include a full blood count, urea creatinine, sodium and potassium, calcium and magnesium, albumin, liver function, glucose, blood cultures, and troponins. CT is often first line for imaging investigation to rule out any catastrophic injury or vascular cause, with many patients presenting with status epilepticus for the first time, often likely having a vascular cause. EEG is often used and is useful in determining the effectiveness of treatment, and is also beneficial in identifying when seizures may not be as obvious, such as in non-convulsive status epilepticus or in anaesthetized patients. Transportation to hospital should be made as soon as clinically appropriate. Many patients with long-term, life-altering consequences of status epilepticus, including death and cognitive impairment, result from patients who have been actively seizing for greater than 2 hours before being controlled by treatment. If seizure activity is not controlled within the pre-hospital environment, immediate emergency transport should be made with pre-notification to the receiving hospital. An attempt should be made at identifying the underlying etiology of status epilepticus, as this can impact treatment and prognosis, which cannot be done effectively in the pre-hospital environment. In times where status epilepticus has been controlled, there is a potential for patient refusal to occur, so clinicians should be aware of the appropriate disposition depending on patient condition. identifying whether the patient can demonstrate competency and capacity, as well as make an informed decision, and ensuring that they're in a safe environment in case of a reoccurrence is important to the safety of the patient. Teamwork is an important factor in improving patient outcome. It consists of cognitive, verbal, and behavioural activities such as communication, leadership, and coordination and decision making. Patients tend to be exposed to greatest harm as a result of poor non-technical skills demonstrated by the clinician. It has been found that increased stress and confusion can arise due to a lack of leadership during resuscitations. Therefore, it is vital that at some point a leader is identified. In one study looking at out-of-hospital cardiac arrest, teams led by leaders with exceptional leadership skills performed better CPR, provided earlier defibrillation, had shorter pre-shock pauses, and reduced hands-off time, leading to providing optimal care. With leaders opting for a more hands-off approach, being more likely to develop a well-structured team, this is important to consider. This approach has also led to improved team dynamics and less errors. Improvement in non-technical skills such as communication, leadership, and decision-making can lead to reduced errors within patient care. Other considerations within the role of a leader include the development of the team and their individual roles. Having an individual nominated as a team leader, with other clinicians on scene providing real-time feedback, is important to ensure the unification of the team occurs. Being able to cognitively offload important skills, interventions, and drug regimes to qualified paramedics allows the team leader to remain in a position of control over the scene. This also ensures that the team leader is in a position to make more complicated treatment decisions, such as extrication and transport, without the clouding of extrinsic factors. Whilst there is significant research performed around seizures and status epilepticus, it is still a poorly understood area within the pre-hospital environment. It has been identified that poor identification, which leads to suboptimal treatment plans, ultimately leads to a poor prognosis. This presentation is aimed at identifying key areas which can assist our organisation in its development of optimal seizure management and highlighting that the time-critical nature of status epilepticus should remain at the forefront of our clinician's mind. The following page is a list of references used to produce this presentation. Thank you for viewing.